Hi, I'm Tammy Potter, and welcome to the Pregnancy Process Podcast, a show designed to help you navigate the hugely transformative journey to motherhood, where you'll hear the unique experience of experts in this area and the incredible stories of women sharing their conception, pregnancy, and postnatal journeys so that you can have a healthier, more informed pregnancy. In today's episode, I talk to renowned obstetrician and gynecologist Dr. Kath Whitton. Dr. Whitton holds a prestigious subspecialty qualification in reproductive endocrinology and infertility, a credential achieved by fewer than 80 specialists across Australia and New Zealand. Alongside her extensive clinical practice, Dr. Whitton also works as a fertility specialist with IVF Australia and frequently lectures and presents to students, junior doctors, GPs, and at medical conferences. In this powerful episode, we'll be exploring the difficult and often taboo topics of unexplained infertility and recurrent miscarriage. Dr. Whitton shares her expert insights on the medical and technical aspects of unexplained infertility, but also shines a much needed light on the lifestyle, mental, and profound emotional challenges that individuals and couples often face on this journey. In addition, we discuss the equally complex and rarely discussed issue of recurrent miscarriage, providing a compassionate medical perspective on this heartbreaking experience. If you or someone you know is navigating the turbulent waters of unexplained infertility or recurrent pregnancy loss, this episode will provide invaluable understanding, expert guidance, and the reassurance that you are not alone. Kath, thank you so much for your time today. It's fantastic to have you here with us.
That's my pleasure. Thank you so much for having me.
I'm really looking forward to this conversation. I think some of the topics that we're going to be exploring a little bit taboo. And I know just recently I had someone come in to see me in person and they're going through the unexplained infertility journey. So this podcast is just so timely. And I was so grateful that I was able to tell her in a couple of weeks, we're going to have a full discussion around this and just ask her if she had any questions. So I'm really excited to have this conversation. And as an obstetrician and gynecologist who you've got a subspecialty qualification in reproductive endocrinology and infertility, you work as a fertility specialist. So you're definitely uniquely placed to talk about unexplained infertility, as well as the relatively taboo topic of miscarriage. And clearly you've dedicated your entire career to women's healthcare. You have a really deep understanding of not only the technical and lifestyle aspects of these topics, but you also have a deep understanding of the mental and emotional aspects as well. And so our audience can get a really good understanding around what unexplained infertility actually means. If it's okay with you, I'd like to start with unexplained infertility and the more medical, technical aspects of this before we move into the more lifestyle, mental, and emotional aspects. Is that okay with you?
Yeah, definitely. It's a complex area.
So let's just start with the very basic. What is unexplained infertility?
Look, I think it can be one of those really, really frustrating diagnoses, but essentially, I guess we're talking about a heterosexual couple, so a male and a female couple who are coming to see a fertility doctor or their gynecologist or their GP, having had difficulty conceiving. So everyone knows that the rough definition of infertility is having tried for 12 months without pregnancy. If you're a little older, however, we ask people to come to us earlier, so within 6 months or so of having been trying. But with unexplained infertility, it's that couple who have been trying for a certain amount of time, who have not had a pregnancy, unfortunately, and that we run a whole sort of gamut of investigations and we just don't really find anything. It's, as I said, it's frustrating because I think people fear that, well, if we can't find anything, you can't help me then. There's no treatment, there's no cure. But that's simply not true. There's lots of different avenues that we can take. But yeah, first and foremost, it's really just not finding anything on investigation.
I can imagine that would be quite frustrating, but also, like you're saying, they want answers and there just are no answers.
Yeah, I think on one hand it's not a bad thing. It's reassuring that we don't find any problems. It means that there are no significant health concerns within the male or the female. But like I mentioned, we all want, you almost want a problem so that that leads us to a treatment or something that we can fix. And it can explain to the couple as to why they're having difficulty conceiving. Most people just want answers.
Something concrete that they can hold on to. So when we're talking about unexplained infertility, I mean, how common is it? What kind of statistics are we looking at here? Like, how many couples are going through this journey?
Yeah. So the stats tell us that 1 in 6 couples will have difficulty falling pregnant, will have that diagnosis of infertility. And amongst those couples that come to a fertility specialist, and we do a sort of whole gamut of investigations, around about 20% of couples will have this kind of unexplained infertility banner placed over them, meaning that there's no problems with the sperm, there's no problems with the female ovulating, no problems seen or identified with her uterus. So yeah, it's up to sort of 20% of couples.
And so I guess that, have you just described how you would diagnose unexplained infertility?
Yeah, so there are a bunch of investigations that can be done for the man and for the woman. For the man, it's largely very easy. It's looking at a semen analysis, so looking at how well the sperm move, how many sperm there are within a sample, how they look. And then for the woman, you've got to think about the ways that natural conception occurs. So she's got to be ovulating, she's got to be releasing an egg from the ovary every month. And that egg then has to meet the sperm. They meet within the fallopian tube. So she needs fallopian tubes that are open. And then she needs a uterus that's receptive or that's going to accept an embryo. So the investigations for her will involve some blood tests, just checking to see if she is ovulating, having a look at her hormones, looking to see if there are any hormonal imbalances, for instance, with her thyroid that might be contributing to her not ovulating regularly. And then looking at the uterus. So usually that will involve a pelvic ultrasound. There is one step further that we can go with the pelvic scan, and that's looking at the cavity of the uterus and the fallopian tube patency. So there are a couple of tests where at the radiology place that does the ultrasound scan, some fluid can be pushed up into the uterus and we can visualize the inside cavity of the uterus and then watch that fluid coming out of the fallopian tubes.
In terms of that, can you explain, because there was something that you mentioned there to do with the fallopian tube. You used a particular word. I was like, oh, what does that mean? Yes, that's the one.
That's okay. So essentially, fallopian tubes are like the little tubes that come off that join the sides of they come off of the sides of the uterus essentially, and they're tubes that at the end of them the ovaries sit around the area. They're not actually connected. The fallopian tube floats around and it picks up an egg from the ovary once it's been ovulated. That egg has to travel up the fallopian tube, and the sperm have to travel through the vagina, up through the cervix, up through the uterus, into the fallopian tube. And actually, the egg and the sperm meets within the fallopian tube. So it needs to be patent or it needs to be open. In some women, there are blockages within the fallopian tubes. Risk factors for blockages include things like sexually transmitted infections, but often we do see blockages and the woman's never had a history of never known to have an STI. Things like appendicitis or pelvic infections can cause blockages within the fallopian tubes. Endometriosis can cause blockages. So there are lots of reasons why tubes may be blocked, and you never know about it if you don't look for it.
That's so interesting. So then I guess that leads us into my next question, which is around potential causes. So especially in the women, obviously, and I think let's focus a little bit more, if it's okay with you, on the female side of things, because like you were saying, the male side of things is relatively simple. And I know that our audience is 90 something percent female. So I think let's focus on that aspect of it, because you are just saying there's multiple things. You've got the hormonal side of it, you've got the egg health side of it, you've got potential blockages in the fallopian tubes, you just mentioned the health of the actual uterus. So there's so many different things going on there. Can we delve a little deeper into the potential causes? Because you have just mentioned a number of different things in terms of blockages in the fallopian tubes, but that's just one small little section of that puzzle. What other areas might be potential causes for unexplained infertility?
Well, I mean, I guess with the name being unexplained, the investigations that we've
Yes,
done
sorry.
have
Like
usually been
if we could explain it, Tammy, I'd be able to tell you.
Exactly. But yeah, look, what we look for is polycystic ovarian syndrome, for instance, the main reason why a woman doesn't ovulate or doesn't certainly ovulate regularly. So we look at her hormones, her menstrual cycle, evidence of high androgen levels, acne, hirsutism, that sort of stuff. In her, we look at her insulin, her glucose, evidence of endometriosis. That's a common cause for infertility. And looking for endometriosis is not so easy. It's something that we can sometimes pick up on simply on taking a really good clinical history, sometimes on physical examination, and sometimes on ultrasound. But I guess a lot of people would know that it's associated with having a delayed diagnosis because the diagnosis essentially is through laparoscopy or an operation to look inside her pelvis. Which is a pretty high risk sort of intervention just to diagnose something. But diagnosing and treating endometriosis may help a couple, may cure the unexplained infertility, so to speak. Inside the uterus, there may be funny lumps or bumps, things like fibroids or polyps, which might be impacting upon the embryo implanting within the uterus. So we want to make sure that we're seeing those and removing them if they're there. They're really the main things that we're looking at.
You mentioned before 6 to 12 months is the kind of timeline that you'd suggest couples try before seeking treatment.
Yeah. Or seeking further advice. There's really no sort of those time limits are arbitrary, I guess. They come from the fact that a couple where there is no health concerns, no sort of identifiable concerns as to their reproductive potential together, that 85% of couples should have fallen pregnant within the first 12 months. Stats tell us that. And within the next 12 months, a further sort of 10 or so percent will have fallen pregnant. So 90 to 95% of couples should have fallen pregnant within 24 months. And really, that's where that recommendation comes from. But there's absolutely nothing stopping a couple coming to us earlier and just seeking a preconception check. That's one of my favorite things to see couples for, just ensuring that they're healthy prior to delving into trying and delving into pregnancy. So, yeah, really seeking help earlier is better in my opinion.
I love that because it's the same as in my realm. If you're thinking about falling pregnant or you're planning to in the future, in the near future, you want to make sure that you're healthy and strong and physically capable and everything's in good working order to be able to maintain that pregnancy and for your body to withstand the physical pressures of pregnancy, all that type of thing. So preconception check, I think this is something that probably needs to be more widely implemented out there, is actually preparing yourself for conception. I think so many people just assume that it's going to be easy and their journey is just going to be like, okay, we'll start trying and then it'll happen. When, the statistics of 1 in 6 couples, 20% are going to be going through this journey. So if they start a little bit earlier, then it may actually see some of these statistics decreasing.
Yeah, for sure. And it's only going to aid your health in pregnancy and your recovery from pregnancy. And then postpartum health, like it just has such a sort of ongoing benefit.
So, when you're looking down the barrel of an unexplained infertility diagnosis, what are the chances of falling pregnant?
So I guess it depends on a few things. Like if I've done all these investigations and I'm talking to a couple about what next, our treatment options, I'll present treatment options to couples in the same way, but I guess it depends on how long they've been trying for, on the female age and their overall health status, really. If a couple are older, maybe the female age is in her 40s, we want to sort of speed this up because egg quality certainly, but number as well, declines with age. We all know that. So she may not have as long of a reproductive lifespan ahead of her as a younger woman, obviously. So we need to speed that process up. So we can start simply with things like cycle tracking, formal cycle tracking, just monitoring the woman's cycle, her hormones, getting her fertile window, really identifying that window and asking the couple to have unprotected intercourse regularly around that time. That might not be my first suggestion, however, to that couple where the female age is over 40, because she probably doesn't have time to keep on waiting to try and conceive naturally. We might be sort of talking about more advanced assisted reproductive techniques such as IVF.
With the treatment options, can we delve a little bit deeper in there? Because we've started with kind of cycle tracking. And just as a side note in terms of that, I think every single woman should be tracking their cycle. I think that it should be like a standard every single month. If you're not using some kind of health wearable, like a tech wearable, like I do, I mean, my Aura Ring tracks my body temperature overnight. It literally gives me very detailed information about my body temperature and my cycle on a day-to-day basis. It gives me information about it. And like, I know that's one extreme because I like a bit of data, but even something so even something so simple as putting a little dot in your calendar each month to say, hey, that's my cycle, so you kind of know. And I think almost going so far as there are physical symptoms that women go through that indicate change, and understanding those. But I think even just as a takeaway tip for anyone listening, if you aren't tracking your cycle as a female, then start, because it is one of your key health indicators as a female. The state of your cycle is essentially your monthly report card to how well your health is doing, and you should be tracking it, in my opinion.
Mine too. No, I definitely agree. I think it's maybe something that should be taught in schools. I'm really pleased to see, I know I see a skewed population, right? I see couples who are coming to me who are having difficulty conceiving. I see a few that come for preconception checks, but almost every woman that I ask, when was your last period or how long are your cycles, they get their phone out. They're all tracking it on their apps, and I love seeing that. So I definitely think, that the younger generation that are coming through now are definitely attuned to doing that.
Amazing. So in terms of that, so we've got cycle tracking, we've got straight to kind of IVF for a couple that is a little bit older. Is there something in between? Because there's got to be something in between there.
Yeah, there is. Like, there's intrauterine insemination, there's ovulation induction. So cycle tracking is just identifying the most fertile window, asking couples to have intercourse. The majority of couples that I see are already doing that with apps, etc. We can tweak things a little bit here and there, but majority, I think, come to me already knowing what they're doing. The next step is ovulation induction in that woman that's not necessarily ovulating regularly. And that can just, again, help to identify her fertile window. The couple will then know when she's ovulating and they can have intercourse around that fertile window. It doesn't necessarily gain any benefit for the woman who is ovulating regularly. It does have a small risk of multiples, so twin or triplet pregnancies, which we absolutely want to try and avoid. So again, not really useful in that woman that's ovulating regularly already. But intrauterine insemination is where we will cycle track, so identify when that woman is going to ovulate and get the man to provide a semen sample, spin it down, get a nice sort of concentrated pellet, we call it, of super sperm essentially. So it's the sperm that are moving really well, a high concentration, and we inject it up into the woman's uterus at a time when we know she's about to ovulate. That avoids the cervix. So the cervix is filled with mucus, and that's quite thick and hard for sperm to get through. So if you imagine the sperm is ejaculated into the top of the vagina, it then needs to make that tortuous path up through the cervix into the uterus, which can be the hardest part for it. So certainly a lot of sperm are lost at the cervix. So if we put a nice concentrated amount up into the uterus, that gives that couple the best possible chance that month. It doesn't increase the chances a huge amount beyond natural conception, but it might be enough for some couples. And if we know that the fallopian tubes are patent because we've done one of those tests, we put a good concentration of sperm up into the uterus, that's a really great chance for that couple.
Amazing. I know people that have tried for 12 months, more potentially. They've already had one child and that's how they conceived their second, because something just wasn't clicking for their
Yeah.
second, and that's what they did. And they just put it a little bit closer together and bingo,
Yeah.
almost straight away.
Yeah.
So that's exciting.
Yeah.
And in terms of success rates, what kind of success rates are we seeing in terms of the treatments available?
That couple that are the female age is less than 35, so natural conception rates are probably between 15 to 20% per month. Not huge. As a species, we're not fabulous at reproducing. We're only supposed to have one child at a time every couple of years or so. And in terms of IUI, it might just increase it a little, up to about 20% per try, maybe a little bit more. For IVF, if the embryos are untested, and I'll go through that in a minute, if they're untested, the chances of success are between 30 to 40% per embryo being transferred. Again, not huge, but almost double, certainly double natural conception rates. There is testing, chromosome testing, that we can do on embryos. So we can take a small biopsy from an embryo and ensure that we're just transferring a chromosomally normal embryo, and that will increase the chances of success even more. So it depends on labs and depends on places. So generally it's between 50 to 60% per embryo transfer in terms of success rates.
Well, that's quite a big jump from 20-ish to 50 to 60, isn't it?
Yeah.
Yeah.
Yeah, it is. It's obviously not without burden to the couple and particularly to the woman.
Mm.
So it's not a light decision, and it's not necessarily necessary for a lot of couples, but it's a good option if that's what you're faced with.
Right. So at what point would you, when you're down this track, would you, let's say you're in that 35 age category, you're not in the 40 plus very short window, you've got a bit of time, you've tried your tracking cycle, you've tried your ovulation
Induction.
induction, that's the one. You've tried all the other kind of bits. At what point would you say, okay, next is actually looking into IVF?
Yeah. Look, IVF allows us to get eggs out of the woman's body and watch them in the lab. So we can see if the eggs are fertilizing. That might be where the issue is. Fertilization may not be occurring for this couple. We just don't know because it's all happening inside the body. So IVF is a good option if the couple have been trying for a while, they have tried these other things. Certainly after 2 or 3 rounds of IUI, I would have expected a pregnancy. So I'd be suggesting to that couple, let's try a round of IVF because it may reveal something more. It may reveal that egg and sperm for some reason aren't fertilizing. That's not common. But the next step after fertilization is that the fertilized egg needs to develop into an embryo, and that takes 4 to 5 days in the lab. That development may be arresting or maybe stopping at some point, which may indicate that the developing embryos are chromosomally abnormal. So there may be chromosomal concerns that we can see in the laboratory.
Mm. It's quite an arduous process, isn't it? I can imagine going through that. You've started this journey and you're 6, maybe 12 months in, still nothing's happening. You've been tracking your cycles and doing those things. And then you go through this process of investigation. If that still doesn't show anything up, that might be a reason for this happening, and then you start doing all of these other things as well. What's the time frame for this? Because I would that sounds like it's at least another 12 months, if not more, going through all the testing, because all this stuff happens on a month to month basis.
Yeah, I think that is one of the hardest parts. And look, I see a full range of people. Some couples will sit in front of me and absolutely want to continue to take their time month by month, continuing on with cycle tracking. We might talk after every couple of rounds of cycle tracking. They may decide to continue. They may decide to then go ahead with IVF. There is also the other sort of side of the fence where people sit down and I suggest things like cycle tracking and they say, no, not for us. We've been doing it at home for the last 6 months. Sorry, we came here just knowing that we want to do IVF. And that's okay as well. Like I'll meet a couple, and I guess a lot of fertility specialists will meet a couple where they are, walk them through what treatments we think they may benefit from. And if that is IVF straight away, then that's the path that we may take. That's not common because we absolutely know that most couples probably don't need it. But, it does sound like a big sort of process. But after I see a couple for the first time, order their investigations, they'll generally come back within the month with their investigations. We can talk about their results. Then you're right, it is a month by month process, because if they do cycle tracking, that's 1 month gone. Then they want to do it again, that's 2 months gone. If they're not pregnant after that, we might suggest IUI for another 2 cycles, that's 2 months gone. So it's 4, 5, 6 months down the track. Yeah, and that's a concern, obviously, with increasing female age. So if she's already coming to me and she's a bit older, then when she's getting older, the eggs are getting older, they're getting less in number and less in quality as well with time. So it's always a consideration in the back of our minds.
And even in terms of the journey of that, it sounds like it would be quite taxing mentally, emotionally, relationally, financially. The impact of unexplained infertility and what it can do to those experiencing it. Can we talk to those different aspects a little bit and discuss what kind of services and support there is out there?
You're absolutely right. Some couples, when they sit down, they're quite defeated. They've been doing it at home alone for quite a while, and they come and we don't find any reason for the problems, and then they don't fall pregnant from the initial treatments that we instigate. Absolutely. I think they feel quite defeated and disappointed and angry. Sometimes it's that full gamut of emotions, right? There's grief as well, that loss of hope, I don't know, just constant disappointment and failure. I think it's are really, really common emotions.
Yeah, I mean, it can certainly manifest in depression, loneliness, anxiety, like you're saying, like anger, frustration. What support is out there to help people who are going through this journey, this unexplained infertility journey? Are there resources out there for them?
Yeah, certainly at the place that I work at and within a lot of fertility companies, we have counsellors who work with us. So we offer free counselling along with our services to couples. So at any point along their path, they can have a phone call, they can have a Zoom consult, they can have a face-to-face consult. The counsellors are really good at making themselves available because we absolutely recognise the big toll that it has on couples and individuals, and that it can lead to conditions, anxiety and depression down the track. So, I mean, they're available through a lot of the big fertility clinics. GPs are also really fantastic resources, and I would encourage anyone to first and foremost talk with their GP if they're experiencing these feelings. And GPs are great at recognizing their local resources as well. So with Zoom consults, etc., I might see an individual or a couple on the other side of Sydney or in another state even, and I don't know what services they have locally. My fertility company can provide a counselling service, but GPs are great at pointing people in directions of local services, that's for sure.
Okay. And in terms of like relational stress, because obviously there's two people going through this as well. It's not always just a woman, it's the males going on this journey with her. And the stress that unexplained infertility can place on all relationships, but it's especially the partnership, the intimate relationship, it can be really high. That you've got things like timed intercourse, sexual difficulties, fertility treatment, and all of that can be super stressful for
Yeah.
pretty much any couple. You've worked in this space for a really long time. Have you got any advice for couples experiencing this?
I think it's talking with each other. It's often about communication, because I think that we all do tend to keep our emotions to ourselves sometimes, but I think that in a partnership, your partner's through this journey. So leaning on each other is definitely very important. Trying to find another confidant to talk to as well, I think, and not just keeping it bottled within can help. So whether that's a family member, a cousin, your best friend, a co-worker, infertility is or has been certainly in the past a bit of a taboo topic, but it is so common. And I think that if people start to talk about it, they'll realize how common it is. So, I mean, that's not for everyone. Some people don't really want to talk about those difficulties at work, for instance, or within their friendship group. But I guess my advice is that communication is key within the couple, and maybe just opening up to somebody else, because you will find someone that's been through a similar journey or that may have a little pearl of advice.
Yeah, that's so true. And you mentioned family and co-workers and that type of thing. I think there's also impact with friends and family when you are going through that unexplained infertility. You might have them withdrawing from or avoiding social situations, I mean, for many reasons. But and I also feel like there's that lack of education around this as well, lack of information, which then has people, how do I say this? Like, you may have friends and family saying things incorrectly or upsetting you, or like they're just not quite thinking about what you're going through or how it's impacting you. And then what happens is that's when you get that snowball effect of people are a little bit flippant with what they're saying in social situations, or they're not being understanding and compassionate. And then what happens is you start withdrawing because you don't want to answer those questions and you don't want to have those awkward situations. So then it's like a double negative, right? So the friends and family, the actual couple, there's just this isolation starting to happen. So to ensure these things don't happen, have you got any information to help friends and family better support those going through unexplained infertility?
It's tough, isn't it? Because I think everyone's different. Everyone has different relationships. You've got that family who are really close and who talk about everything together. But then you've also got those people within your family who are more reserved and don't really want to talk about things. It's so hard. I think it's just a matter of knowing each other and not, gosh, it's so hard to say, isn't it? But like not prying. But then again, on the other hand, it's helpful. It's helpful to have your people on your team, on your side, there to talk to about these problems. But it's got to really be met with that compassion, because it's a really tough journey. And unfortunately, there are couples who may not ever get there and who will continue to struggle and won't get the outcome that they want out of all of this. And that is an unfortunate reality. But suffering emotionally and mentally is another big reality of this journey. And so just knowing that you do have the support there, that the people to lean on, to talk to when you want to. So, like I said, the family and friends, not necessarily prying for information, but just being available and just asking if they're okay, if there's anything that can be done, if there's anything that they can do, I think is important.
Because it is quite a delicate topic, especially for those who aren't childless by choice, let's just say. That's what we're dealing with here. And I feel like even now, because I fall into that category, I would say, and even now that I've processed a lot of stuff around this and I'm okay with this, don't get me wrong, but every now and again, there's a little comment or someone says something. And one that I get quite a lot is, "You don't understand, you don't have children." "Oh, you don't
Yeah.
understand." Like, that flippant, "Oh, you wouldn't understand" comment, that is like a dagger to my heart. So I guess maybe that's why I'm asking that question, because I do kind of understand people going through this journey. It's difficult, especially when you've got friends or family members who do have children and they're dealing with their own stresses around having kids. And then it's kind of like, "Oh, well, you wouldn't understand." And maybe I'm answering my own question here, because these are the kind of things that I think people just need to have a little bit more understanding and compassion, and just a little bit more, just take a beat. If you're dealing with someone who doesn't have children and is in that childbearing age bracket, whether they're
Yeah.
partnered or not, just take a beat to how you're actually addressing things to do with children, their journey, that type of thing, and just understand that maybe it's not a choice of theirs. Because the other thing is, some people, like you're saying, some people go through this journey and just don't tell anyone.
Yeah.
So that couple might be going through rounds and rounds of IVF or something like that, or they're going through this entire journey and they haven't told a single soul. So I think I have answered my own question there. And that is probably a little bit more. I think we just need to take a beat when dealing with people who are in that childbearing age bracket who haven't been open and out there with, I'm childless by choice. I made a decision not to have children and I'm good with that. If people don't fall into that category, I think we almost need to then take out our kid gloves and just be very careful around the subject of fertility for those that don't have children. I think that's probably, yeah. Sorry. I just so answered my own question there.
I think the take home message really would be that it can be frustrating, very frustrating. The whole journey of infertility can be very frustrating, but when there's no cause found or no reason for a couple not conceiving spontaneously, it can be really, really frustrating. But in the vast majority of couples, we get there.
Oh, that's really hopeful, helpful advice right at the end of that, to know that most couples,
Yeah.
a fair majority, you get there in the end.
Yeah.
I like hearing things like that. In a similar realm, and I understand that miscarriage is not in the same round of unexplained infertility, and unexplained infertility is where you cannot fall pregnant, or there's reasons why you're not getting those two blue lines, right? You're not getting that positive result. And then we're going to veer off into a slightly different area that's almost just as taboo, and that is miscarriage, because we all know in the process of falling pregnant that this is a very real potential that can happen, and many women do experience this. Many couples experience this, and I feel like it's almost a taboo topic as well. It's quite shrouded. There seems to be a lot of shame around it for many women. And I feel like there is a connection here in that women suffering from unexplained infertility and multiple miscarriage, they would feel like their bodies are failing them. They'd have that real sense of inadequacy, like there's something wrong with them. To help with these feelings, especially for those who are going through or have experienced miscarriage, can we talk a little bit about the reasons why you might be experiencing a miscarriage?
So I guess first and foremost is that in the vast majority of cases of miscarriage that we never know why it happened. And in the majority of cases, there is no reason. And it's nothing that the woman's done or the couple's done or could have prevented. That's something that I find myself saying quite frequently to a couple, because the first thing they say is, what did I do? Is it because I ate this, I exercised, I did this, I went on a plane trip? They want a reason. They want to be able to explain it. You said the word shame before. That's exactly right. There's so much blame, often on the behalf of the woman. She often just blames herself, and she's shrouded in shame, certainly for the initial kind of experience of miscarriage. But common reasons for miscarriage happening are because there's a chromosomal abnormality within the embryo, and it unfortunately was never going to progress into a pregnancy and then into a birth. That is probably the most common reason. There may be some health concerns for the woman if she's got something like diabetes or uncontrolled high blood pressure. Again, so rare in a usually young, fit female population that are falling pregnant. But if she's got uncontrolled sugars with a diagnosis of diabetes or blood pressure problems or abnormal anatomy or shape of the uterus, that's another reason for miscarriage. But usually, like I say, the reason's not known.
So, health factors, let's talk about health factors a little bit, because you've just jogged my memory. We haven't really spoken about those much in terms of this journey here. So, when it comes to health factors, besides from the high blood pressure and the diabetes, what other things in terms of health factors tie into these two topics? And I understand that we're talking about two completely separate things here.
Yeah.
Is there anything that crosses over, or did you want to talk specifically about the unexplained infertility and then miscarriage?
No, I guess you're right. They do cross over because it's really just female health that's going to promote a healthy pregnancy. So, whether it's falling pregnant in the first place or continuing on with a pregnancy, preconception health and then pregnancy health are really, really important. So, if she's got medical conditions, for instance, which are poorly controlled or newly diagnosed in pregnancy, they may contribute to either difficulty falling pregnant or miscarriage. So, autoimmune disorders, things like thyroid dysfunction, whether it's low hypothyroid, so low thyroid hormone, or hyper, so high thyroid, can impact upon fertility. Diabetes, like we've said, other autoimmune conditions, things like lupus, which many people may have heard of, or clotting abnormalities within the female. They can all impact upon fertility and risk of miscarriage. Sometimes with recurrent miscarriage, we will investigate those kinds of things. So we'll do a whole gamut of investigations looking into the woman's immune system, looking for autoimmune abnormalities and her blood clotting ability. We also look at her chromosomes, her chromosomal makeup. We might look at genetic carrier screening amongst the couple. In fact, that's something that's recommended for all couples looking to fall pregnant. So, looking to see if the man and the woman are carriers of certain genetic mutations, which may make them at risk of having a child with a genetic mutation. Yeah, they're really the main things that we would look at. I guess the message is to optimize health and to optimize any kind of medical conditions that she may have prior to falling pregnant.
I mean, that's what it all comes back to, right? It's that preconception, doing what you can before you try and fall pregnant and being in the best possible health that you can be in for that journey, because it filters through everything, really. It
Sure.
actually filters through your entire pregnancy and how you cope through it. The healthier, the fitter, the stronger you are, the better you're going to cope with the pressures of pregnancy. And that includes falling pregnant in the first place. Now, in terms of genes, when it comes to the compatibility of male and female, are there some people that are just genetically more compatible and some people that are just genetically incompatible?
Good question.
And
And
is there a test that you can do?
well, yeah. So it's certainly recommended that any couple looking to have a pregnancy together has genetic carrier screening. It can be done in so many different ways. It can be done ideally prior to pregnancy, but it can also be done during a pregnancy. And the idea is that we all have pairs of chromosomes. We get one from our mum, one from our dad, right? And we all carry genetic mutations. It's just that we have two copies of each chromosome. So if we have a mutated copy, we usually have a balanced, a good copy, and that kind of takes over. But if a reproductive couple, a man and a woman, both carry the same genetic mutation, they're at risk of having a child with that genetic disorder. The most common one that people will have heard of is cystic fibrosis. So a child's born with cystic fibrosis if the mother and father both carry that same genetic mutation. So now we can do testing. It's a blood test or a saliva swab from both parents where we check if they're carriers for certain conditions and identify those couples that are at risk of having a child with an abnormality. And if they are at risk, then they can choose to do IVF and test their embryos to see if the embryos carry or are affected by the condition. And if they choose to do that, most couples would choose not to put back in the embryo that's affected by the condition.
But going one step further than that, actually looking at the compatibility one step deeper than genetic mutations. Is there anything going one step further? Like maybe they are just not genetically compatible.
Not necessarily. There's all. I mean, look. There's things like we can check chromosomes. So the woman's chromosomes, the male's chromosomes, they may carry certain conditions on their chromosomes. So structural rearrangements that have led that couple to having recurrent miscarriage, for instance. But that's something on the individual's chromosome. So on the woman's or the man's chromosomes. As a species, where genetic diversity is key. So you will hear about certain populations where there's breeding amongst first cousins and consanguinity occurs, and those populations do have increased risks of genetic mutations and genetic conditions. So to avoid those, avoiding having a reproductive relationship with a first cousin, for instance, is advisable. You laugh, but it happens, and it does happen in certain countries and certain populations. And we
Accidentally?
do know that no, but we know that there are consequences of that, and that's increased risks of genetic abnormalities. Because I guess biologically we're supposed to be promoting genetic diversity, so that's breeding outside of our own sort of genetic pool.
Okay. Because my brain's starting to think along the lines of like pheromones and how some people just, if like maybe there's something deeper in that. But I think before I end up on a complete tangent, I think let's bring it back to. You're like, no, Tammy, the science says no. But when it comes, and sorry, because we are actually talking about it is quite a serious topic, and I should probably not be so jovial around this topic. So,
That's
for anyone that's a bit offended by my happiness right now when we're talking about a serious topic, I apologize, but I'll put my serious face back on again now. So, when it comes to miscarriage, and in terms of someone who's experiencing recurrent miscarriages that you've mentioned previously, what types of evaluation and treatment options would be available to someone who's going through that particular journey?
So, recurrent miscarriage, it's sort of a definition that's changed over the last few years. We used to say 3 or more consecutive miscarriages, so in a row. Now we've dropped the word consecutive and it's reduced to 2. So, any woman that's experienced 2 or more miscarriages, whether they're consecutive or the same partner or not, it doesn't actually matter. Nobody wants to even go through one miscarriage. So, I don't even bat an eyelid if a woman comes to me and she's experienced one and wants investigation as to why it may have happened. The reason why historically, I guess, we haven't investigated a couple for recurrent miscarriage earlier than 3 is because in the vast majority of cases, we actually don't find a cause for it. But investigations will involve things like blood tests for her and an ultrasound just to ensure that there are no problems with her blood's clotting ability, with her immune function, her insulin, glucose, thyroid function, her chromosomes. We do chromosomal testing for her as well. And then an ultrasound again to look to see if there's any anatomical cause why this may be happening.
It is a very serious topic, and it so often happens in the first 12 weeks, and so many people don't share their news. And because of this, I feel like so many people that have experienced miscarriage, they do suffer in silence.
Yeah.
And as a society, we just don't have the same rituals around grieving and or practices around grieving or a life lost for one that's not even really had a chance to begin versus what we do for those who have had a full life, a life fully lived. So when it comes to people that are going through this journey, what kind of support is out there for them?
Look, I think there are this is really well recognised now, I think, and there are some amazing organisations that provide advocacy for this group of people. There's certainly support services like Miscarriage Australia, who have an incredible website, who have lots of sort of online groups and groups that you can join. There's Pink Elephants, they've got a support network, which again provide peer support services. You can arrange to have like live online chats and calls from support people as well. Red Nose have bereavement counsellors that you can access. I think if anyone's experiencing this, just a quick Google search for those kind of support services will come up with a whole gamut. I think we're in a really lucky time that we've got a huge awareness as to the needs of couples and individuals experiencing miscarriage now. So there's so much help out there. I know that everyone says that there's help there, there's help available, but amazing organisations like I've mentioned, like Pink Elephant are the ones that come to mind, Miscarriage Australia and Red Nose.
Yeah, because I can imagine that when you're really in it, it's hard to reach out for help or pick up the phone and call these organizations. So I guess just taking that first
Yeah.
step if you need to is really important. And just before we wrap up, do you have any advice specifically for couples that may be experiencing recurrent miscarriage?
I guess it's definitely to seek help, because I did say that in majority of couples we don't find a reason for it, but in some couples we do. And it's almost akin to unexplained infertility. Just because we don't find a reason for it doesn't mean we can't help you. There are treatments available. So it may be that we go down the assisted reproduction path, because, and I certainly have with couples that have experienced recurrent miscarriage before, because they want to do IVF, they want to test their embryos because it's something that they don't want to experience ever again. So they want to optimize their chances of success in terms of pregnancy. And IVF with genetic testing of embryos is a way to increase the chances of success.
Absolutely. And it is so important that we do support people going through this, because there is an aspect of miscarriage that really steals a woman's happiness, her ability to feel joy when in the hopeful event that she falls pregnant again. It robs them of something. They can't settle into, they can't feel the joy of
Yep.
subsequent pregnancies because they're so scared that something's going to happen. And that makes me really sad when I see people going through that. It does put them really on edge. Now, I have one last question for you, and you can feel free to answer this in any way possible. I feel like I might know how you're going to answer this, but I'm gonna see. So, what's the one thing that you wish all women knew before having a baby?
I'm interested to see what you think my answer is going to be.
You're like, what did you
It's probably
think?
completely different. It's probably completely different to what you think.
Maybe I would say that it's got to do with your preconception checks.
Oh. Well, that is a very good one, and I wish that I was saying that. I think, so like you mentioned, I'm really fortunate to deal with couples at the beginning of their journey and at the end of their journey. I see them through pregnancy and postnatal care as well. And I think that people concentrate so much on fertility and the pregnancy, but the postnatal period is where there are so many challenges, and that can be such a tough part. I want people to be prepared for that. And my advice is that no one really knows what they're doing. We're all making it up, and there's no right or wrong. You can prepare yourself as much as you want through the pregnancy for that postpartum period, but until you hit that sleep deprivation, you have that little one in your arms, it's really difficult to know. And I think that there's no rights, there's no wrongs. And like I mentioned, no one really knows what they're doing. We're making it up as we go, and you just do the best that you possibly can.
I love that. That's such great advice because it is so true. I get women coming to me training hard, ticking all the boxes, doing all the right things through their first pregnancy, and they're like, yeah, I'll be back at 6 weeks, I'll be back at 8 weeks, and I'm like, let's take it as we come. We don't know what kind of baby you're going to get, we don't know what kind of birth you're going to have, you don't know what kind of sleeper they're going to be, what kind of feeder they're going to be. You're stepping through into this huge unknown. That birth is the first cycle of your maternal
Yes.
metamorphosis, but then there's the whole other cycle that comes with being a mum. So I love that. Thank you so much for sharing that. And I think also that ties back into something that I was thinking before around we seek reasons for the unexplained because we are humans are certainty making machines. Everything needs to have an answer or a reason, and we need certainty around things. So I can understand why people would hold on to there being a reason for this, like
Yeah.
genetic abnormalities or endometriosis or some kind of concrete issue that they can say, this is the reason why. And that's a psychological thing that I think all humans have. They need certainty in things. And I think when it comes to unexplained infertility or recurrent miscarriage. Sometimes these things are just unexplained.
Yeah.
And I guess it's having that support system around you to help you through that journey and making sure that you're connected with the right doctors like yourself. That was such an enlightening conversation. Thank you so much for your time today.
No, thank you. It was great.
And if you're hearing this message, I want to say a huge thank you, because it means that you've listened to this entire episode. Of course, if you have any questions about the things that we covered in this episode, or want to know more about me or my other projects, you can find me on YouTube and Instagram at The Pregnancy Process. For those currently in their conception or pregnancy journey, you can apply to join my complimentary but private community, the Preggy Training Crew. And you'll find my community application and social media links in the episode description. And of course, if you enjoyed this episode, I absolutely encourage you to share it with other women just like you. And I look forward to seeing you in the next episode.